we talked about clinical indicators of dialysis efficiency, but what is an adequate dialysis? And this question is it's been asked for last 40 years. We sometimes come to an answer, sometimes we know that there are a lot of things that. So to know the assessment of hemodialysis adequacy and how to achieve it, we have Dr. Rajapurkar with us, who is going to talk on this. To chair the session, I invite Dr. Vadia and Dr. A.V. Godbole to come up on stage. Oh, sir.
Shall I start? Good morning. Let me thank Vipul specially, Valentine and sir to give me a chance to come here again and talk to this gathering. I missed the first two editions of Dialysis Beyond Textbook. So, anytime one talks of adequacy of dialysis, most of the answers most people give is KT by V, only solute clearance. So if you achieve solute clearance, does it mean you have actually achieved adequacy? Now in patients who, I will not go into the details of trials, but just to mention historical landmark trials of why KT by V is important. It is important, but not the only thing that is needed for. So you get a very good KT by V and a dead patient, and an underdialyzed patient with a normal KT by V. So there are many facets to achieving adequacy, and we'll try to discuss that now. So what is the definition of adequacy? This is the definition in the dictionary, the quality of being good enough for a particular purpose. So what is the purpose of doing maintenance hemodialysis? Is it so that you get enough return? Is it so that you can sign and collect your fees and go home? Is it? So my definition of the purpose of doing dialysis is to get as good a quality of life for as long as possible for our patients. Now how do you achieve that? What determines adequacy? Solute clearance or KT by V, though praised as well as maligned in many places, is very important. The factors which affect solute clearance, and there are problems with KT by V also. It requires an adequate vascular access, which gives enough blood flow and returns it back without any high venous pressure. Frequency of maintenance hemodialysis matters, like we've learned from the frequent nightly hemodialysis networks and daily hemodialysis networks. Duration of dialysis session matters, like Lobo was talking of 12 hours and 8 hours and every day. So duration of matters, and the nutrition on dialysis matters. And there are other factors that will come. When dialysis started early, in the 70s and 80s, nobody knew what they are doing. If the patient just survived for that dialysis, people were quite happy. Now, what are the variables when you are estimating urea kinetics modeling? The variables are the volume of distribution of urea, and this is one thing which is an estimate based on the patient's weight at that point of time. Urea generation rate, now we don't actually measure this often. It's again an estimate. The protein catabolic rate normalized is also calculated, and it's incorporated into an equation which becomes easy, and with the internet now available on your smartphones, you don't even need to know the equations there. I also put up the calculator that is available, and you can put in your pre-dialysis and post-dialysis blood urea nitrogen into the equation, put the patient's weight, and then it will calculate everything for you and give you a KT by V, and you'll accept it as normal. Then you have multiple types of KT by V. One is a single pool KT by V, then there is a weekly standard, then there is equilibrated. And if you look at it this way, that if you are doing 2 times a week dialysis, here is 2 times a week dialysis, and if you have got a measured KT by V of a single pool kind, if you go below the 1.2 mark, then your chances of dying is higher, as well as when you go above 1.6, again your chances is again a classic U-shaped relationship there. So what are the things that you enter for different calculators? You give pre-dialysis urea. Post-dialysis urea, how do you calculate post-dialysis? When do you measure this post-dialysis urea? When do you take that blood sample? Now, ideally, what would happen would be you removed a lot of urea from the blood, but there is a lot of urea still distributed in the rest of the body, intracellularly and all. And it may take 6 to 8 hours. And for your measurement of KT by V, if you call the patient, say, come back after 8 hours for a blood sample, vast majority of patients would choose somebody else as their dialysis person rather than coming back. So, will you do it immediately after? Will you do slow flow? What is the idea of slow flow? What is slow flow? Do you reduce the dialysis rate flow as well as blood flow, or only the blood flow? Does the equilibration between the blood compartment and dialysate compartment for urea actually equilibrate during that slow flow? These are all the problems of KT by V. Now, the first study was done by the National Cooperative Dialysis Study, where this is the first multicentric randomized controlled trial to investigate the impact of dialysis dose on patients' outcome. Mind you, at that time, only 151 patients were randomized to 2 different timed average constant of blood urea. Some of them used serum urea nitrogen to begin with, and 2 different treatment times. One was 2.5 to 3.5, which was common in American dialysis units, simply because then in a given day you could do more dialysis shift and earn more, and a longer dialysis time. So 4 groups became there, and there again the endpoint was a poorly defined endpoint. Is the need for the hospitalization as a poor surrogate marker for survival? Now, whenever you had low pre-dialysis blood urea nitrogen and long dialysis was the best for preventing hospitalization, whereas high pre-dialysis BUN and short dialysis was a prescription for disaster because you needed more hospitalization. So this is the first time a randomized trial across US states was done. Then came the National Cooperative Dialysis Study, the effect of hemodialysis prescription on patient morbidity. This is a part of the same study, those 151 patients only, and so the report summarizes the morbidity of 151 patients. The sample size obviously is very small. They had excluded many with comorbidities. So this has been severely criticized, particularly the amount of money spent on this dialysis by the US government. So, and it's now historical, so I'd suggest it is a good idea to go back to the original publication from the NEJM and read it. Then this Ghosh and others decided to reassess that into a mechanistic analysis of the National Cooperative Dialysis Study. The purpose was to determine the probability of clinical failure over a known level of dialysis. So they converted this to a catabolic rate of grams per kg per day, and then arrived at an equation of KT by V, and then showed in their analysis that you have to have a KT by V of 1.2 to 1.4. This is where the KT by V first started. Then the dose of hemodialysis and patient mortality in the USRDS study. This was published in 1996 August. Now, to 2,311 patients from 347 dialysis units. Estimates of the relationship of the delivered hemodialysis dose and mortality with a statistical adjustment for extensive list of comorbidities and risk factors. Patient follow-up range from 1.5 to 2.4 years. You can obviously see that this, to generalize this to today, is rather difficult. The patient follow-up, the mortality risk was lower by 7% at a very significant rate, with each 0.1 higher level of delivered KT by V. Expressed in terms of urea reduction ratio, mortality was lower by 11% at each 5 percentage points higher URR. Above a URR of 70%, KT by V of 1.3%, these data did not provide statistical evidence for further reduction in mortality. The same thing from that study, you can see this. As your relative risk of dying, you get a 1 at around 1.2. So that is for the single pool. Now, effect of dialysis dose and membrane filtration, the HEMO study, this is 2002. It was designed to determine whether further increases in dialysis dose above the current standard of 1.2 single pool KT by V or the use of a high flux membrane would improve patient outcomes. 1,846 patients randomized to either high dose target urea, equilibrated KT by V, which is a calculation from single pool by a complicated formula of 1.4, the approximate single pool KT by V of 1.65 or a standard dose, and the target KT by V of EKT by V of 1.05, which approximates to a single pool KT by V of 1.25, the dialysis and to a high flux where mean beta 2 microglobulin clearance was more than 20 ml per minute, or a low flux, mean beta 2 microglobulin clearance less than 10 ml per minute per membrane. These are in vivo figures, not actually done during the study. The mean follow-up period was very good, 4.8 years. The range from less than 1 year to 6.6 years, depending on the time of randomization. In this study, what did we find? Almost no difference in mortality if you have achieved. The patients undergoing hemodialysis thrice weekly appear to have no major benefit from higher dialysis dose than recommended by current US guidelines and from the use of high flux membrane. So neither the flux, but now if you looked at the forest plot in that study, favors high flux when it comes to some, but you can see the standard deviation is large enough, crossing 1. So really, it did not show much benefit in most of them, except in very young people in a subgroup analysis. Young people without cardiovascular or other comorbidities, which were not included in the study, it showed benefit. So dose of MHD in India, therefore, treatment guidelines that we had written, as it has been referred for some time, that since 1981, inadequate dialysis has been shown to adversely affect survival, while increasing the frequency and duration of dialysis improved both survival and quality of life, and reduced the medication amounts. It was therefore recommended that KT by V or urea reduction ratio be used as a measure of dialysis prescription. URR is a simpler method to determine dialysis adequacy. That those days people had to calculate the KT by V by a handheld calculator. So it should be targeted to more than 65%. The post-dialysis sample should be taken 2 minutes after the dialysis or during slowing of the pump speed to 100 ml per minute and the sample taken 15 seconds later, and this should be stopwatched and taken. A KT by V of 1.4 to 1.6 single pool should be achieved at each dialysis, is what we recommended based on the evidence that was available to us at that time. What about frequency of hemodialysis? Now, in-center hemodialysis 6 times per week versus 3 times per week. 125 patients were included in this frequent hemodialysis network trial group, again published in 2010. In the frequent group, 5.2 dialysis sessions were given per week, and the KT by V achieved was 3.5. Whereas in the standard hemodialysis, 3 sessions per week, and the KT by V of 2.4. And in the conventional group, for 120 patients were compared with the 125. Now, if you looked at this graph, you can see the frequent dialysis showed improvement in survival, and most of the parameters like the reduction in LV mass, physical health composite, Beck depression score was better. Albumin did not achieve the significance. Pre-dialysis phosphorus was much better, favored long dialysis daily. ESA dose, not very significant. Pre-dialysis systolic blood was good, but not really significant. So this showed a benefit of doing multiple dialysis over a long period of time. Now, prescription of twice weekly hemodialysis in USA. Now, many of the patients would want to do twice a week hemodialysis. So, in USA, they retrospectively analyzed frequency and characteristics of 2 dialysis sessions per week. A sample of 15,067 adult hemodialysis patients were utilized to compare twice weekly with thrice weekly therapy in logistic regression. Factors predictive of twice weekly hemodialysis were older age, Caucasian race, female gender, higher serum albumin, lower serum creatinine levels, lower body mass index, high estimated renal function at the start of ESRD was also predictive of twice weekly schedule among these patients. Cox-adjusted survival analysis indicated a lower mortality risk, RR of 0.76, for twice weekly hemodialysis compared to thrice weekly among the prevalent patients. Argument against this paper was that retrospectively these patients had better residual renal function amongst other characteristics, and thus had lower mortality rather than anything to do with dialysis itself. Now, there are other 2 studies of twice weekly hemodialysis in China. Frequency associated with patients and treatment characteristics of quality of life in China dialysis outcomes and practice pattern study. A total of 26% patients in China were dialyzing 2 times a week compared to less than 5% in other DOP regions. Standardized KT by V was the lowest in China, 2 compared to other regions, 2.12 and 2.27. Again, females, shorter dialysis vintage, lower socioeconomic strata, less in health insurance coverage, lack of diabetes and hypertension were associated with dialyzing twice weekly versus thrice weekly. Patients dialyzing 2 times per week had longer treatment times and lower standardized KT by V, but similar quality of life scores were achieved with 2 times a week, and people use this paper to argue for doing 2 times a week. In fact, this paper is very good to argue for incremental dialysis, that you start with 2 times a week. As your residual renal function goes down, then you can increase the frequency to 3 times a week. What were our guidelines? Indian NHD guidelines says that the patients on MHD must receive 3 times a week dialysis in a week for at least 4 hours each time, with blood flows of 300 ml per minute and dialysis flows of 500 ml per minute. Now, MHD less than twice a week or less than 8 hours in 2 sessions is simply not recommended, because there is no way in which you can do that and achieve any mortality. But those on twice a week dialysis may be given longer dialysis, maybe 6 hours each time. And it is important to realize that in those patients, they should have residual volume, residual urine of more than 300 mils, a residual renal function, GFR of about more than 3 mils per minute. If you don't have these, then it is no point in doing two times a week dialysis. Association of initial twice weekly hemodialysis treatment with preservation of residual renal function in ESRD patients. Again, this is a 65 MHD patients, 30 of them were initiated on twice weekly HD for 6 months or longer, and 55 patients were started on maintenance on 3 times a week treatment. The subcohort of the study, 48 incident MHD patients were implemented to assess the independent risk factors responsible for residual kidney function decline during the first year of HD therapy. Multivariate logistic regression analysis was then employed to examine the odds of renal residual kidney function loss. This study concluded that twice weekly hemodialysis during first year of dialysis therapy appears to be associated with better residual kidney function preservation. Multivariate analysis showed that factors such as male gender, HD frequency, URR, intradialytic hypotension episodes were associated with residual kidney function loss, and the odds ratio of residual kidney function loss in each additional HD treatment per week was 7.2. So, what did we say in India? This study is often widely quoted, Chauhan and Mendonca. Adequacy of twice weekly hemodialysis in end-stage renal disease patients at a tertiary care 50 patients on twice per week hemodialysis were assessed for 1 month. They were divided into 2 groups, study group, one whom dialysis was monitored and session length enhanced to meet the minimum standard of KT by V of 2, in the control group where KT by V was not monitored. There was a significant improvement in the hemoglobin levels, mean arterial pressure levels, serum albumin levels, and the WHO quality of life score in the study group compared to the control group. Again, small sample size, no inclusion of really difficult elderly diabetics with cardiovascular morbidity patients in this, and this follow-up was not long enough. So it is not great to generalize this. So the duration of MHD session, shorter length dialysis sessions are associated with increased mortality. Now this is Jennifer and others in Kidney International 2013. Now if you looked at the odds of, this is your hazards ratio, and this is 240 minutes, and you shorter duration, you will get poorer results. Longer duration, that was the reason for recommending that if you're doing twice a week, extend the dialysis session. This is more details of the same study, 87 patients randomized to 42 in conventional group and 45 in frequent nocturnal hemodialysis group. Longer duration of dialysis, more frequency, survival benefits over a period later on. Survival and hospitalization among patients using nocturnal and short daily compared to conventional hemodialysis, USRDS study. Now, nocturnal hemodialysis is here. Sorry. You have it here, 7.5 mean Uh, 8 is the session time, and the range is 4.5 to 8. Standard hemodialysis, this is chronic hemodialysis, this is short daily hemodialysis, and this is nocturnal long dialysis. Now, sessions per week, 5.7, 5.4 versus 3.5. The blood flow rate, 200 to 300 in nightly hemodialysis, same for single daily hemodialysis, and 250 to 500 in the chronic dialysis program. Dialysate flow rate was 200 to 300 in nightly, 300 to 800 in single daily, and 500 to 800. Single pool KT by V per session, 1.1 to 1.8 in night hemodialysis, and 3.8 to 1.26 in the single daily, and in the chronic dialysis, 1.55. Now, if you looked at what happens, who does survive better? Clearly, the night hemodialysis, and the longer the dialysis, you seem to do better when you adjust to many things. KT by V and survival on dialysis as related to the age. Now, this is a 2014 paper of American Journal of Nephrology, and did large number of patients between 2001 July to June 2006. In one of the 580 US patients outpatient dialysis facilities of DVTAP dialysis centers, conventional Croc's proportional hazards regression model was to study the association of baseline SPKT by V or timed average constant of single pool KT by V with the mortality was separately assessed. One was assessed by usual method and one by a special statistical modeling. Two, time averaged single pool KT by V was averaged of single pool KT by V obtained from each calendar quarter for each patient during the entire follow-up period. Models were adjusted to entry calendar quarter, age, gender, race, ethnicity, Hispanic, non-Caucasians, African Americans, Hispanics and Asians. Dialysis duration categories were less than 6 months, 6 to 20 months to less than 2 years, and 2 years to less than 5 years, and more than 5 years. Primary insurance, types of vascular access, AV fistula versus graft versus catheter, presence of diabetes, pre-existing comorbidities, history of tobacco smoking, body mass index, serum levels of albumin. So extensive adjustment. And what did we find? Now, KT by V and survival, the 3 times per week negative relationship with baseline single pool KT by V and the mortality, whereas timed averaged single pool KT by V showed a strong negative association with mortality. So it's clear that you give more filtration over a longer period of time, you seem to do well on hemodialysis. The same thing is shown in greater detail. I would not labor through, and the references are available with me. If people want, I will be happy to share the originals with you. Now, what about the age of the patient? Effects of KT by V, urea on outcomes according to the age of the patient on maintenance hemodialysis. The guidelines say 1.2. This study was used to use the hemodialysis quality assessment program, and claims data sets of patients were divided into 4 age subgroups. People aged less than 65, between 65 and 74, 75 and 84, and 85 and above. Each group was divided into 3 subgroups according to KT by V urea. The reference was 1.2 and urea equal to or 1.4, low was less than 1.2, high was 1.4. And the details of the results are given. The conclusion of this study was the results support the concept of recommendations of the maximum KT/V for urea 1.2, even in patients aged more than 85. In young patients, KT/V urea above the recommended dose threshold can be beneficial for survival in younger patients. But this has been shown right from the beginning. What are the problems with KT/V? Multiple retrospective analysis of Fresenius database suggests that relationship between gross mortality and delivered HD dose has a reverse J contour. The HEMO study and RCT raised doubts by failing to provide evidence that delivered KT/V, SP KT/V greater than 1.3 improves survival. Recent retrospective USRDS analysis demonstrating an inverse relationship between mortality and delivered single pool KT/V urea, even for values greater than 1.7 per treatment. Data from adequacy of peritoneal dialysis, Mexico, ADMEX study, the prospective randomized study indicated that an increase in urea KT/V along with weekly creatinine clearance over a clinically relevant range did not improve the survival of chronic peritoneal dialysis patients. Factors that affect small solute clearance in hemodialysis. In the blood compartment, hemodialyzer mass transfer area or area coefficient. The access-related issues like flow, recirculation, which is often misunderstood or not calculated by most units, improper needles, improper cannulae, improper calibration of blood pump. Every month we missed out in the initial discussion that you have to calibrate your blood pump to what you actually obtain as a flow and what is shown on the machine. That has to be done at least monthly. Inadequate anticoagulation and therefore using up of the fiber bundle by clots. In the dialysate compartment, packing density and fiber undulation, crimping is one of the factors. Presence or absence of spacer yarns and fiber bundle spacing. These are the things that matter on the dialysate side for achieving the correct KT. Nutrition, that's the other important thing. If you get a lot of KT/V, good KT/V, in a thin, small individual with poor muscle mass, you will achieve a lot. But will the patient do well? Surely not. So you require to simultaneously look at the nutrition of the patient. And I realized that the tastelessness, the anorexia, the vomiting, if you're doing good dialysis, the nutrition must improve. And if after starting your dialysis, your patient's pre-dialysis urea does not start rising, creatinine does not start rising, and the dry weight does not start rising, then you're doing something wrong. And that's where the nutrition comes. The factors of malnutrition in chronic hemodialysis patients are extremely well known because they come with malnutrition. They have reduced protein energy intakes due to hundreds of reasons. And often it is psychological because nobody sat down with them and talked about it. Primary intercurrent illnesses like infections, their catabolic rates, chronic inflammation, particularly in places which often are missed. And very few of us actually go on to look for dental caries, a chronic ear infection, intertrigo, particularly in diabetics, particularly in between the toes, is hardly ever examined. Edema is seen with the socks on, just on the shin, and nowhere else in the dialysis units. Endocrine and metabolic disorders, acidosis, uremic toxins, anemia, hyperparathyroidism per se, hyperleptinemia, growth hormone and IgI resistance. The dialysis-related factors, of course, inadequate dialysis, bioincompatible membranes, which has become very less now. In my times, we have used cuprophene membranes too. Chronic inflammation due to the disease state itself, an active lupus, even when end-stage disease has happened. Endotoxin backfiltration, poor water treatment, amino acid and protein loss in the dialysis, and vitamin losses in the dialysis. Nutritional parameters and chronic hemodialysis. The clinical parameters, you look at the body weight. Actually, the dry weight is a very important index of nutrition, and it should start going up. You have to keep on revising every month or every 3 months the dry weight. Arm muscle circumference, make sure that you're measuring it exactly at the same point every time. You can't measure it up and down in a given patient. You need to look at the skin fold thickness, triceps skin fold thickness, and you should have a vernier caliper in your unit. Growth rate in children, subjective global assessment has been shown. And then there are other biological, to my mind, you can look at the normalized protein nitrogen appearance. And I wish the students in this group tell me the formula of calculating this, and when do you take these samples and send it to my email. I promise you I'll send it back for the correct answers. Normalized protein catabolic rate, here is the formula. So I will not tell you more. There are calculators available nowadays. So if you got the right parameters put in, your Google will give you everything. Nutrition parameters and mortality in incident hemodialysis patients. Now, here in this study, the conclusion was that a reduced mid-arm circumference and low energy intake at the beginning of the chronic dialysis program are risk factors for mortality, and a negative effect of high BMI on survival was associated with reduced mid-arm circumference and longer dialysis vintage. It is extremely important that if you do not, your patients will die more if you're not only, even if you're giving good KT by V, but you're not looking at nutrition. Your patients are more likely to die. So what quality of life are you going to measure after he goes to that Yamasadan of yesterday? Now, if you looked at the BMI at the beginning and the survival, the lowest survival is in the BMI of equal to and less than 25 kilograms per meter square, mid-arm circumference of equal to 90% of the ideal. So it's very clearly shown that these mid-arm circumference, triceps skin fold thickness, and anthropometric measures, diary recall, protein calorie intake calculation should be vital in dialysis units, because it's vital for your patients. Like you measure your blood pressure, you measure your sugar, you have to measure nutrition. There's just no shortcut to it. So 2.5 kilocalories per gram per day versus less than 25 kilocalories per gram per day, clear separation of survival curves. Now, again here is a NPCR in grams per kg per day versus all-cause death hazards. Now, your hazards are best when your NPCR is between 1 to 1.2 grams. Now, you go below 1 gram per kg, your mortality starts increasing. And there is some reverse J-shaped curve for this also. Now, what can be achieved if you really did this only? So you looked after nutrition, you looked after small solute clearance well, gave good efficient dialysis. What is the quality of life? So what are their requirements? You need to sit with your patients and ask for their aspirations. And I'll illustrate this with a case study here. Can be achieved. This was a 15-year-old ESRD, a Bharatanatyam exponent, from the age of 7 years. Kidney transplant, mother donor, graft failure 10 years later. Came to me for asking for doing a unrelated donor transplant. because everybody at home was finished. So I said, at least give 1 year to dialysis. And then if you don't feel better, I'll send you to somebody who will do your unrelated donor transplant. So after about 3-4 months on dialysis, she looked depressed. So I sat with her and talked to her as to what do you want to do. She said, I want to dance. I have not danced after I have got into transplant, simply because my face, due to steroids, became so gross that I didn't dare to go onto the stage. So I said, do you want to do it now? And she said, yes. She went on to do dialysis, to complete her remaining training of Bharatanatyam. She restarted training 3 years after maintenance hemodialysis. After that, in 1 year, she arranged an Arangetram and invited me as the chief guest for that. The publicity of that was great, in the sense she arranged a dance program for celebrating her 25 years of kidney failure. And that was in the main Tagore Hall of Ahmedabad, where it was full, chock-a-block full. Again, I was called as the chief guest and she performed. That's where she got an idea that she could do charity shows through her dance, and collected a corpus of 90 lakhs of rupees for poor patient benefit within the unit. And she was the only person after Mayuri, that's my daughter, who could threaten me and Dr. Maheshbhai together. This is her on dialysis. And she, whenever I would come for rounds, she would pretend sleeping because I would ask for intradialytic weight gain and fight with me. And I would say, okay, fine, next time you get it more than 2.5 kilo, I'm just increasing the dialysis time to 6 hours. So that is the threat. And if she didn't eat, then I would say, okay, fine, I'll put in a Ryle's tube. Simple, no problem. Here is an ADPKD, 1997. He was supported financially. See, Nikita, the first patient, was herself a rich person. Now, if your employer, if you're not rich, what do you do? Today, you have got so many of yojanas, and the government is spending huge amounts of money without asking what is it giving, what is it getting in return for that. Here is an ONGC employee, ADPKD, with one daughter, also an ADPKD. His wife said that I'll give the kidney to my daughter when she grows up rather than give it to my husband. And the both agreed. Now, in November 2005, this is the quality of life. He worked his full life, dialyzed for 28 years, and succumbed to a cardiovascular disease later on, and not related to the dialysis. That is possible. Now, here's another patient. His previous history is that he had a kidney transplant done in 2014 when he was a just past engineering graduate. Due to his kidney transplant was done in 2014, mother's kidney. Due to recurrence of FSGS, his kidney was lost. Second transplant, when you lost the first graft in 5 years, and in fact the recurrence happened within the first month. He passed 12 grams of protein within the first month after transplant, went through plasmapheresis, rituximabs, multiple other treatments. Nothing stopped that proteinuria. In fact, 3 years after the transplant, I angioembolized that kidney just to prevent the protein loss to get his nutrition okay. Then he was on home hemodialysis. He started dialysis in my unit in 2020. Then he went on to home hemodialysis setup in 2024. And since home HDF setup in March 25, the price of a home hemodialysis setup at home is 11.5 lakhs, and the session cost at home 2,250, includes the technician cost. Now, if you did that, you might save a little bit. His current schedule is alternate day dialysis, 4.5 to 5 hours. a monthly target being 70 hours on hemodiafiltration. The setup cost of a hemodiafiltration at home was 30.9 lakhs, and the cost per session is about 3,500 at home. He is so fit today that he has gone on a business trip to Tokyo and did his one dialysis there. This is his home dialysis machine with the water treatment for his setup at home. He refuses to learn to cannulate himself. So I know he is completely capable of. He says, if I can afford a technician which is the least of the cost, I don't want to worry about my fistula failing. So he is prepared to employ a technician. So that way, he is doing extremely well. Now, this is the statement he made 3 days ago when I asked him to make a statement about his quality. He says, with dialysis, routine life is important. I go to office on weekdays. After dialysis, it is very tiring. So I generally do dialysis in the evening so that after dialysis I can sleep. I work regularly and I'm involved in the research and development of a chai machine that they manufacture. It is those tea vending machines that they manufacture of variety, 1 cup, 2 cup, 3 cups, this powder, that powder, and so on. He got married on March 2023. And his wife was always very supportive and understanding of my schedule and dialysis. I knew her from 2016. So she has seen me go through all phases of kidney failure and transplantation to then dialysis again. She gives me strength to be strong enough and face life of dialysis. Still, we fulfill our life goals and live well. That is what can be obtained. So what does it require? Therefore, the aim for hemodialysis is good quality of life for as long as possible. So how does this direction go? You have adequacy of hemodialysis as one part, adequacy of nutrition as the header of the arrow, but it is propelled, the arrow is propelled towards that by treatment of comorbidities correctly and by family support, social support, and of course financial support. If these three are not there, this arrow does not go forward. So when you talk of adequacy, don't talk only of KT by V. Look at nutrition, family support, and make an effort to see that that person gets a gainful quality of life so that almost normal quality of life is possible. And your aim should be to try and achieve that. Thank you for listening to me. Lastly, the success of hemodialysis depends not on you, the nephrologist. The quality of technologists or nurse more than the nephrologist. Repeatedly doing the same thing again and again without taking any shortcuts can be a challenge. There is no intellectual challenge day to day. There is boredom. Burnout of the personnel, including caregivers, and poor outcomes are due to poor resources and bad disease. I believe all nephrologists should invest in their support structure of social worker. Actually, one of my students once asked me, what is the secret of your success? I said, marry a social worker who is very capable. I was very lucky in that. So, well, thank you very much for the patient listening, and I'll be happy to answer questions and take comments.
Would you prefer to sit down?
I'm fine.
Oh, okay. Anyway, thank you so much. But I think the most important thing today is that assessing his patient's quality of life goes well beyond correcting his chemistry and his physiology. Only thing I would slightly contrarian view, I agree absolutely that the quality of the technician and the social worker, etc., is of paramount importance. But in the end, it is the nephrologist who has to enthuse them and to coordinate them.
Agreed, sir.
And
Completely agree.
And I think that you pointed out that the nephrologist has really got to be a true physician in the right
Yes.
sense. Any questions? I'm sure there will be plenty.
Ambikar, sir, Richard.
Just one question. In the times when we started dialysis, if you remember, it was 5 hours 3 times a week. Now it is 4. So, what made that change? That was point number 1 and point number
Nephrologist convenience and economics.
Okay.
So economics and politics invade all activities of human endeavors everywhere. So
It's
you
not-
have to decide what is your aim.
Second is, did you require the services of a psychiatrist any time? Because when
I was lucky, I had one at home. But yes, the need for a psychologist to assess and counsel not only the patient, but the patient's immediate caregivers, particularly to prevent the burnout syndrome part of it, and make arrangements to see that their children's education is looked after, comorbidities of their parents, the requirement of the job for that particular individual, his reimbursements, the paperwork, all that is needed. And the psychological assessment allows you to decide whether the patient is really depressed or not. Marital adjustment should be checked. Mental health status can be checked. Actually, there are 3 or 4 psychological questionnaire-based tests that you deliver to every patient, score-based, and then you can actually measure the mental health checklist. Then you can measure the anxiety depression scale. Then you measure the quality of life subjective global assessment or kidney specific SFA 36. All that you can measure, but you need people to do that and trained people, because those questionnaires, and there are what should I say, accredited translations of these questionnaires passed by the Indian Psychiatry Association. Those are available, and anybody wants them, just write to me or Sujata. She will also tell you how to give it.
Is it the job of the doctor also to look at the financial aspect and the social, not medico-social, but the family social, this thing? I think it is, because I think most of us don't do it.
It's not that way in the job description. But if you want to achieve the aim that I stated, as long as possible, as well as possible, you must facilitate. And you may not do it yourself, but you can facilitate that through somebody who reports to you back. And that way, a coordinated team of your paramedical people, patient's family, and the environment in which that family is living, you can make a change. Should you be paid for it? My answer is no. Should you take part in it? Must. Yes, sir.
Has the patient's point of view taken into consideration in any of the adequacy definitions? What are the patient's goals,
Well, that was
aspirations? What
yeah.
do they expect from life? Does that figure anywhere in the guidelines?
Well, at the time of guidelines, I was not very aware of this, but do you know Dr. Prabir Roy Chaudhary, originally in Cincinnati and now the president of the American Society of Nephrology? He initially started involving patient advocates in developing patient-oriented studies where patient advocate was one of the important members of the steering committee for studying. And the first thing they did was to find out what is important to the nephrologist and what is important to the patients. So they rated each. The nephrologist rated what is most important to Obviously, they started with KT by V and URR, and then NPCR and so on, and the blood pressure. And when they asked the patient, they said, can I travel? Can I go on a vacation? Can I go on a trip? They are more important than doing this. So the patient perspective must be taken into consideration. Obviously, autonomy, and you will be one day made legally responsible for it. So before that, if you actually involve patients, I have been a patient myself too for a chronic and life-threatening situations many times. And I have found my physicians hardly ever talk to me. And I resent it. I resent it clearly. And I feel that it would have been, I sometimes also feel that all physicians must once in a while get a life-threatening, not life-taking illness, their patient outcome will change.
Thank you for the excellent talk, sir. Two things that I learned about this particular aspect is asking patient what work they are doing and how they are doing that work, and are they finding any difficulty in doing those work. One of our dialysis patient works for armament factory, and doing adequate dialysis for him is our duty towards nation, that he is working for armament factory that is helping nation. So that is something that I learned from you. Second thing I learned from this lecture is I should restart removing patient socks and look at the ED market. May I request Dr. Wadia to hand over token of appreciation.
Before that, I'd just like to say one thing, that I think we should give special thanks to Dr. Rajapurkar, who has given us 1.5 days, despite not being in the best of health, and also showing us what a really all-around nephrologist and physician can do.